a senior lecturer in health economics and law and professional development at Deakin University. So that sounds like a very interesting area to get into.
And lives with a Fontan circulation.
Well, that's right. Has a very interesting life and lives with a Fontan circulation. And you host a podcast, is that right, Pat?
That is true, yeah.
What you'll have to tell us a bit about that.
Yeah.
Go on.
So it's a podcast about philosophy. So I'm an academic philosopher, actually, and I work in bioethics. So it's a podcast about art and philosophy called Concept Art.
Rachel, do you want to introduce Kate? You probably know Kate better than I
I'd
do.
love to. So everybody, Kate English is the head of adult congenital heart disease at Royal Melbourne Hospital, and we're very lucky because she's relocated to Australia in 2024 from the UK, and is someone I'd admired for my whole career. So now it's very cool because we actually get to work together, and she's an extremely experienced international expert in adult congenital heart disease and obstetric cardiology. Hello, Kate. Thank you so much for joining us.
Good morning, Rach. Thank you very much.
And for those of you who have just joined, AJ Iyengar is a cardiothoracic surgeon who's based in Auckland and deserted us from Australia. But just in case, I think quite a few people have sort of joined on in the last bit of this session. So hello there. And Julian and I are your hosts today, in case you missed that.
I think over to Pat and Jane to moderate the panel.
All right. So Pat and I guess as part of the ANZFAC committee, we were sort of wanting a session a bit on, I guess, what you might call common complications. So we've come up with a few pre-prepared questions for the panel. So we'll start off with those, but then I'm sure people are welcome to come on board with their own questions. So I have got the first question, which I'm going to ask of Kate. So Kate, when I see my cardiologist, he often tells me that people with a Fontan might experience a racing heart rate. He's always going, is it racing? Is it racing? I've never felt that personally, but I have had episodes where I felt quite faint and lightheaded. I've been told that if I have these sort of regular episodes like this, I might need to take medication for an irregular heart rate, or I might possibly need a pacemaker. Do most people with a Fontan circulation have rhythm issues, and how are they treated?
Okay, so I'm taking one step back. Just going to say thank you to Jane and to Rachel, Julian for welcoming me today. Fontan Registry is admired worldwide, and when you come from outside into this, it's a real privilege. So thanks, everybody. Arrhythmia, it's not universal in every Fontan patient. There are plenty of patients who never get heart rhythm disturbances, but it's definitely common. It gets commoner as people get a bit older. And there are two types of heart rhythm disturbance that people get. So people can get fast heart rhythms or they can get slow heart rhythms. Now, fast ones are much commoner in Fontan patients, and they're commoner in certain types of Fontan. So Ajay's already talked about the different types, and we certainly see fast heart rhythms much more commonly in patients who have the kind of what we call old-fashioned atriopulmonary Fontan. They're less common, but not, they don't never occur in patients with the kind of more modern types of Fontan. So particularly in the extra cardiac conduit, we don't see that much, but we do still see it, and that poses its own challenges. So it's certainly one of the things that's always at the forefront of our minds when somebody comes and says they've got symptoms. So if people are saying they've got episodes where they feel faint and lightheaded, we will always think, well, is that a heart rhythm disturbance? So if you get palpitations with it, so a feeling of the heart racing associated with that faintness and lightheadedness, then we'd be pretty clear that that was the cause. But if you don't, then maybe it's something else in play. But we would investigate whether there's a heart rhythm disturbance going on. that can be done in a number of ways. So lots of people will have had Holter monitors over the years, often multiple. You'll find that a Holter monitor is a great cure for any kind of heart rhythm disturbance. You put a Holter on and they never occur. So if we just put Holters on everybody 24 hours a day for the rest of your lives, you'd never get another rhythm disturbance. So we use we're moving slightly more into different methods of investigating for heart rhythm problems. Heart bugs, lots of people will be using, and they're really good. So that's a monitor that people wear for 30 days. It triggers if there's a heart rhythm disturbance, and it sends us a magic email and gives us a trace of what's happening. But again, heartbug 30 days, nothing may happen during that time. Now, there's increasing evidence for the use of wearables. So looking at, and actually I'm quite surprised at the accuracy of them. So I was just looking at a paper recently looking at the use of smartwatches to diagnose atrial fibrillation. And some of them are better than others, but the technology is getting loads better. So there's certainly going to be, increasingly useful to use things like Apple Watches and the sensitivity, so the way that the kind of accuracy in picking things up is really pretty high. So you're looking at 96%, 97% for some of them. Fitbits look terrible actually in comparison to the other ones, but so Samsung watches and Apple Watches are both pretty good at doing that. So that's another way. And then, so if we see people who have fast heart rhythms, they often present in two different ways. So in some patients, they'll go into the abnormal rhythm and they'll stay in it, and they get stuck in that rhythm. And that often can make people feel really poorly, and it can make them quite poorly. Not immediately, and they're not immediately life-threatening, but they can cause people to drop blood pressure and feel pretty ropey. And if that happens, you're in for an ED visit, I'm afraid. And usually the way that we get people out of those rhythms, if they're stuck in it, is with an electrical shock treatment to the heart to resynchronize things. And quite a few people who are attending today may have had one or more of those procedures, and they're quick, they're risk-free. We usually get you sorted, get you out of hospital usually the same day. If we're getting people that go in and out of fast heart rhythms, then tablets are the usual mainstay of treatment. Sometimes a bit of trial and error to get the right ones. Some people suit different medication a bit more than others. And we always start with kind of simple, straightforward ones like beta blockers. And we move on to the stronger ones, that stronger usually equals more side effects. So we move on to those if we fail with one of the simpler ones. Sometimes we get people with recurrent episodes and we end up sending those to see our electrophysiology colleagues, and some people will end up with procedures called ablation to try to get rid of the fast rhythm, the site where it's coming from, particularly if they're in and out of hospital, frequent admissions. And occasionally we'll then move to the next step, which is a further electrical procedure called AV node ablation, in which case there's a pacemaker needed as well. But that's pretty rare, and pacing in Fontan patients carries its own technical difficulties. Now, a word just briefly about pacemakers is that pacemakers are only there to control slow heart rhythms, not fast ones. So some of them do have anti-fast pacing technique or technology within them, but they're generally there to control slow heart rates. So hopefully that's been brief enough. Basically, fast heart rhythms, pretty common, get commoner as you get older. They're rarely dangerous, but they can be a real nuisance.
Thank you.
Thanks so much, Kate. That watch pot never boil strategy is it sounds like a winner. So thanks so much, Julian, for introducing me. I'll just sort of recap. So I'm a 38-year-old person with a Fontan circulation. I was born with something called double inlet left ventricle, and I had my Fontan operation completed all in the one procedure when I was a kid, when I was 2. And I've since had a couple of different re-interventions, most recently in 2023. But I live in Nipaluna, Hobart, in Lutruwita, Tasmania, with my partner and our 8-year-old daughter. And as we talk about these complications, I've actually had, to a greater or lesser extent, all of these complications, and I still feel like I'm in pretty good nick, really. My health is quite good. My life is quite happy and good. So all of these complications can be addressed and can be managed. So the next one that I want to ask is actually to Rachel. I want to ask you, Rachel. When I was at high school, we did sprints in phys ed class, and afterwards I felt sort of so exhausted that I could barely move. I didn't collapse or anything, but I was like, could hardly move. And the teacher called an ambulance for me, and I got sort of taken away to hospital for a little while. And after a very short time, I recovered completely, except for sort of my pride and my reputation around school. But how should people with a Fontan circulation manage their exercise intensity? And what do we do when we're tired or fatigued after exercise, or even just sort of after daily life?
Yeah. Great questions and commonly heard stories. I'll talk in detail about exercise intensity and things this afternoon, but in general, on average, people with a Fontan circulation, if you were to push them to their maximal exercise capacity, on average, people get to about 65% of what you would probably do if you had a normal heart, or what someone who had a 2 pumping chamber heart without complex health conditions would get to. So you get to about 2/3. In general, that doesn't affect you if you're just walking or sort of doing light things. But when you're doing those more extreme things that have higher requirements like sprints, that becomes much harder. And when anybody exercises, after exercise, your blood vessels dilate. You might also have been a bit hot and a bit dehydrated. And so it's much more common after intense exercise to get low blood pressure and feel a bit fainty. And I suspect that's probably what happened to you. And it's really important in all of our view as kind of clinicians that we help our patients to be able to participate, and coming up with ways where you can do sports and not be stuck sitting on the sideline. But some of those things like sprints are going to be really hard. And unfortunately, we've done a very bad job of coming up with plans and working with schools and parents to sort of work out ways of keeping you involved rather than being stuck on the sideline. I think managing fatigue is extremely difficult. I mean, all of us, I know even for myself, I'm just so exhausted in my day-to-day life that I just do not have time to exercise. And I think that's even more exaggerated when you're a parent who has a Fontan and a busy job. I think not putting too much pressure on yourself and just doing little things, and also thinking about incidental exercise, like in your day, what can you do? Like, can you park a bit further from the bus stop or the train station? Can you say to yourself, okay, I'm only going to get the lift if it's more than 3 flights of stairs? Little things like that, so that, and those things in your day add up to be, half an hour, 40 minutes of exercise. So I don't have magical answers, and we'll talk more about like data and proper exercise training later, but they're pretty frustratingly general answers though, I know.
Thanks, Rachel.
Now, we do have a question from the audience, but it's more about the previous topic about arrhythmias. So I don't know if we're best to go back to that, or should we wait until the end? What do you guys think?
You're the boss.
Oh my God, don't tell me that. Pat, yay or nay?
I think let's go through the kind of common things that are all on the table, and then we can revisit. Yeah.
We can do it. We can do it. All right. So our third question, my question, is to Julian. So I know this question may not apply to everyone here, but I know some people, including me, with a Fontan, take anticoagulants or blood thinners, such as warfarin. Being on warfarin, I often bruise easily, and if I have a cut, it bleeds for a long time. How do people using anticoagulants manage the risk of bruising and bleeding? And what can they do if these side effects are having a significant impact on them? So, for example, I usually get quite heavy periods, that sort of thing.
That's a great question. So, I guess the first thing to discuss with your cardiologist or your child's cardiologist is what, for my particular health situation and my particular type of Fontan circulation, what is the best anticoagulation for me? Because there is as we heard with AJ's talk, there are a few different types of anticoagulants, and it's not a kind of one size fits all. There's a number of things that we take into account when deciding what type of blood thinner to use. I think it's pretty relatively uncontroversial that some form of blood thinner is required in children and adults who live with a Fontan circulation. The common ones that we use are aspirin, warfarin, or a group of medications called NOACs or DOACs, like rivaroxaban is one example. So the first thing to ask your cardiologist is, well, what is the best type of anticoagulant for me? Generally speaking, the aspirin doesn't require any specific monitoring. Warfarin does require monitoring, and with warfarin, the monitoring is a blood test which you can do either through collecting the blood from the arm or from the finger prick. And if you're on warfarin, the question you should clarify with your specialist is what level of anticoagulation you need, because you may not need the same degree of blood thinning on warfarin as someone, say, with a artificial heart valve or who's had a previous stroke. So that's important, because the kind of degree of warfarinization does have an impact on your bleeding. With the NOACs, they generally don't require monitoring, and generally you can get fairly stable levels. With the warfarin, the levels can be more up and down, and that's important as well, because that can affect your bleeding risk. Sort of managing day-to-day things that cause bleeding, you do have to be kind of aware of certain things. I think we discussed already that, you know, certain sports may not be possible on warfarin because of the bleeding risk. If you have contact sports and you get knocked in the head, then that's not going to be very good. If you're yeah, you do have to manage certain sports and, you know, things like that with a little bit more thought before embarking on them. But generally, most activities are safe, and you can stop bleeding fairly well from a cut, or and bruising generally is not major bruising like in a joint, or that's pretty rare in my experience. With regard to menstrual bleeding, again, it would be important to speak to your cardiologist and also a gynecologist if it's particularly difficult about how to manage that and what the underlying causes there may be that can exacerbate the bleeding on an anticoagulant.
Do you mind if I pipe up about the heavy periods?
Yes,
as a female and a female cardiologist of older women, heavy periods is a huge problem in especially in Fontan physiology, and actually, we're doing a big survey about it at the moment. So if you're interested in participating, let me know, because we're trying to, in my experience, this is managed very poorly. So there's probably a lot of reasons why women have heavy periods with a Fontan circulation. The pressures in veins are higher. There's other factors associated with having a Fontan circulation that make you more prone to bleeding. I've had patients come into hospital shocked from heavy menstrual bleeding, needing massive blood transfusion. So if this is a problem you're experiencing, please mention it to your cardiologist. But we avoid the pill that has estrogen in it is not safe for women with a Fontan circulation. And so generally we try and avoid that. And it's important that there is somebody expert managing you and your period, and advising you correctly about what medications are safe. And you do not have to live with a torrential period. We've got very, very effective therapies. And I get so angry when people have just sort of been encouraged just to put up with it, because you really do not have to. But the aspirin can make it a bit worse, but in my experience, the newer warfarin type medications like rivaroxaban and apixaban and things can make it really bad. Kate, I'm interested to hear whether that's your experience as well.
Yeah, absolutely. Certainly the NOACs seem to be the worst culprit. Warfarin is often bad, but
Yeah.
NOACs make it worse. But I think, just to reiterate, there are really effective gynecological methods of manipulating that, and we shouldn't be expecting patients to simply put up with menorrhagia.
And personally, Larissa, you've asked, is tranexamic acid contraindicated? I do not. I tell the ladies I look after to not let anybody give that to them. And I've had a couple of patients have clotting events related to tranexamic acid. I think there's not a lot of data about it. And I have noticed in other states or with other doctors that sometimes they don't seem to mind so much. But particularly in Fontan physiology, my preference would be do not use it. Kate, I don't know what you would say.
Yeah, I mean, if you've got somebody that's admitted with menorrhagia and they're really struggling, balance of risk and benefit, I'd probably say yes, use it to get control of this particular episode, but let's look for a better long-term solution, because using tranexamic acid on a monthly basis is not a long-term solution. That's sticking plaster. So Suzanne's put in the chat, my daughter's on rivaroxaban and doesn't have bleeding. That's excellent news.
Yeah, it's not everybody.
It's not everybody. Yeah.
With as you get older too, your periods tend to get heavier. Yeah.
Thanks so much, Julian, Rachel, and Kate. That's all really interesting and really important information. So the next question, I might direct it to Rachel, but maybe you might want to farm it out to get other people's views as well. The main thing that I remember doctors monitoring when I was a kid, when I would go in for my kind of annual checkups, and I'm sure they were monitoring lots of things, but the number that I remember them talking about, or the thing that I remember them talking about, was a leak in one of my valves, which had always been there, it had always been mild, and it was sort of monitored progressively. And there was nothing that needed to be done about it until I turned 26, when my cardiologist decided that the leak was too big and my aorta had dilated a bit. So basically they decided to do a reintervention to replace my leaky aortic valve with a mechanical valve. Are leaky heart valves common? Are they a problem, and do they always sort of need to be replaced?
Yeah, great question. And I think we would have answered this question differently 10 years ago. So when you have Fontan physiology, for it to work really well and to last you decades, and we're hoping to get people decades and decades of life with really half of a functioning heart. We want everything to work really well. And just little things that might be tolerated in a 2 pumping chamber heart. Sorry, I live in Newtown, Sydney, and there's a plane flying over right now. So I don't know whether you can hear that. So just little things that wouldn't be so important for a 2 pumping chamber heart can really markedly affect the functioning of somebody's heart who has a Fontan circulation. And traditionally, we used to kind of sit on things a lot more. And primarily led by the Fontan registry data, we've recognized now, and we saw signals that if we just sat on people who had moderate or severely leaking heart valves, they just don't do as well in the long term. And that's been a very strong signal in all the data that severely leaking heart valves in particular, people don't do well in the long term. And so we have become more and more aggressive with when we intervene on leaking heart valves. And so that might be the outflow valve, which is usually an aortic valve, or it might be the valves in the middle of the heart it might be a mitral valve, it might be a tricuspid valve, or we might call it an atrioventricular valve. So you might hear all those terms. So and it's not always clear-cut decision making. So we have to weigh up what is this person's risk for an operation? What is their heart pumping chamber capacity? What's their exercise capacity? And it's really individualized decision making. But I think it would be fair to say, and I'm keen to hear what Julian and Kate think, that from the time we start to see a moderate degree of leaking, we've really start thinking, okay, that when am I, we just need one more thing to sort of tip us over into thinking we've got to get on this now, because if we wait too long and the leaking starts to be really severe and that the circulation function is declining, the risk for surgery really goes very high. And I've got a few patients who have severe leaking, and because they've got such high surgical risk, that for them, rather than fix the leak, we might actually go for transplant in those people. We've got a couple of people who were really high-risk surgical candidates that we've been able to avoid doing open heart surgery for with a valve replacement, and we've been able to come up through the leg and put a little clip on. Now, that's not going to be as durable and last them as long, but it's sort of a Band-Aid to get us more time. And there's more and more evolving therapies where we can avoid an open operation. But for most people with a leaking heart valve who aren't in our most high-risk category, we want to jump on it earlier than we would in a 2-pumping chamber heart, and it's going to mean another open heart operation and usually a valve replacement. And then that will be either a metal valve that signs someone up to warfarin, or sometimes for various reasons we might think it's safer with a tissue valve so that we're not wedded to being on warfarin. Julian and Kate, would you add anything to?
No, I agree that we do start, thinking hard about it when the leaking of the valve has gone more than just mild and moderate or severe. We do try hard to look and see if the valve can be repaired. And that's an operation that uses the valve tissue itself, and the surgeon tries to make that valve tissue function more effectively. Often repairs are quite challenging to get very good for a long period of time, and so there's quite we have to think through carefully about whether it's better to just replace the valve up front. But you might hear that discussion around repair versus replacement. Certainly, leaking valves tend to occur more common if your single pumping chamber is a right pumping chamber. The heart normally has 2 pumping chambers. One is a right pumping chamber, one is a left pumping chamber. And unfortunately, leaking valves tend to be much more common when the single pumping chamber is a right pumping chamber, and seems to tolerate, the right pumping chamber seems to tolerate leaking less well than if there's a left pumping chamber. But it's not, doesn't occur in everybody, but it occurs in enough people that that we do have to look carefully for that.
It's a bit tricky too. One thing I've noticed is that in adult land, like when Kate and I meet you, we're thinking, okay, how am I going to get this person to be, an old person? Whereas I've noticed in the pediatric land, and Julian, you may be a slight anomaly to this, but there is more of a focus, how do I get this kid through childhood with the least number of procedures? And you will notice that there's quite a different approach when you come from child land to adult land. And it's a difficult conversation because often we'll meet you for the first time and think, oh, shivers, I'm going to need to do something about this pretty early. And that's not been the conversation that you've had with your pediatric doctor. And there's a number of reasons for that. One of the reasons is that when we put in an artificial heart valve, it doesn't grow. And so in childland, they really want to avoid putting in an artificial heart valve because they've got these little kids who are going to outgrow that valve. And whereas once we look after you when you're fully grown, and we're not quite so worried about you outgrowing artificial heart valves. But there is a very different lens, I think, to pediatric versus adult.
I entirely agree, Rach. I think our approach is that we're trying to keep you and your heart as good as possible for as long as possible. Whereas there is, in the pediatric world, we want you to be going to school and doing sport and doing all those activities and not necessarily, 2 or 3 operations in hospital over and above what you've already had. So that is different. I think the assessment of leaky valves, and someone's put something in the chat about magic numbers and for function and pressure, and this is reflective, is that one modality of imaging doesn't give you all the answers, and we will usually use multiple modalities to look at various different aspects of that leaky valve and how the heart works. And I like to use serial imaging, and if we start to see changes in volumes of the heart, so which demonstrates to you the heart is not coping with that leaky valve, that is a trigger to do something about that. You can cope with a reasonable degree of leak for a period of time, and that quite a lot of hearts are in a period of in status quo, and they don't really change very much over quite long periods of time. But we're looking for subtle changes in heart muscle function, size of chambers, to trigger that that track of let's think about doing something else. Because as Rachel says, these interventions do carry risk, and we're not doing them if we don't think that they're needed and are going to give you a good outcome.
I think an important thing to appreciate is that people with a Fontan circulation are like snowflakes. Like, I can't think of any other condition where there is such an incredible array of differences. And so the decision making is very individualized and extremely complex. And it's not as simple as hard and fast numbers. And it's very difficult. Even I don't think most other cardiologists understand how incredible the Fontan circulation is, but it is so different and heterogeneous across the population.
Apologies if you can see somebody hiding behind me.
So I've got cats crawling all around my background. So.
All right, I think we're down to our last pre-prepared question, and I believe we're going to give this one to Kate, at least start off with. So I'm aware that my liver can be affected by having a Fontan. What sort of tests or monitoring might my doctor ask me to do to keep track of my liver health?
Okay, this is something which doesn't particularly raise its head very much in childhood, starting to in teenagers. And I think that we've all become increasingly aware over the last 10 to 15 years about the impact of the Fontan on liver health. So that can be quite confronting. And I think that sometimes we use language which people are, do find difficult. So cirrhosis, is a word which has connotations for people, and that can be a little bit difficult. The impact of the Fontan on the liver tends to be age-related again. So, time from Fontan is a determinant factor in how significantly the liver is impacted. But that's not the only thing that goes into the mix. And we do certainly see some younger patients who have a degree of liver involvement. The tests are relatively, they're not particularly invasive, but it does add a whole layer of complexity and, visits to hospital, which are, quite frankly, a bit of a pain if you're young and you're at uni and you're trying to live a life and you're trying to go to work and do all those other things. So essentially, what we do is blood tests, usually once a year, maybe once every 2 years, liver ultrasound, and there's an argument ongoing about the use of something called RFI, which is an assessment of liver stiffness. Now, that assessment is used in kind of bog standard liver patients to assess the degree of fibrosis, but it's not been validated in Fontan patients, and it may not be that useful. So almost all of our Fontan patients have abnormal RFIs. They don't necessarily have fibrosis. If you've got normal liver function tests, so on blood tests, and you've got a normal liver ultrasound, you don't need anything else doing for the next year, definitely, maybe 2, and that's kind of out for discussion at the moment. If the abnormalities are seen on the liver ultrasound scan, they're often just changes in what the liver looks like. It can look a bit bumpy, it can have different areas of different shading within it. And then sometimes the liver team or the radiology team will recommend liver MRI if you can have MRI, sometimes CT. So it really depends on, the baseline imaging. The baseline is blood tests and liver ultrasound, and then we move on from there if we see things that we're not that, that may represent other changes. But it is an additional burden, I think, of investigations and clinic appointments and other things. And, we're working on ways to try to bring that under our roof. In the UK, we used to run it just through cardiology, and we would have an MDT with the liver team. And if we had people with significant liver changes, they would then go to liver as well. But the majority of patients who didn't have that would go on a green traffic light, which was annual ultrasound and annual bloods. And if they were okay, they'd get an MDT discussion and they wouldn't see the liver team. It would all be done within one appointment with cardiology. And that's something to maybe mirror.
Yeah, that's how we have a clinic with a liver specialist. So it just makes things easier for the people who need a bit closer monitoring. One thing point I just want to make is that if you go and have a liver ultrasound at your local radiology place, or even at my hospital, annoyingly, they put the liver stiffness on a table and say that you've got advanced liver scarring or fibrosis. And that creates so much distress for patients, because but please, if ever that happens to you, throw it out the window, because your vein pressure is higher. It makes the liver stiffer, and it doesn't, that table should be chucked in the rubbish when you have a Fontan circulation. So that I just...
Can I add a question to that? And I think it's probably in these settings of kind of non-Fontan specialty gastro clinics and things. But we have sometimes had people come to the Fontan community and ask questions and express concerns about getting recommendations to have a biopsy for their liver.
Yes.
Do you have feelings about that?
So I'll tell you my thoughts, and then I'm interested to hear. But we do have guidelines about this now that some of us have written, have been part of. So there is no role for liver biopsy to characterize fibrosis routinely in the setting of a Fontan circulation. There is a role for biopsy if we're seeing a nodule that looks a bit unusual or suspicious, because very rarely it's quite common to get a thing called regenerative nodules in the setting of Fontan associated liver disease, just because there's a change in the signals in the little cells in the liver. Very rarely those nodules can become a bit concerning and might need to be removed. And so if we're worried about a nodule, yes, that will need a biopsy, because we need to check whether the cells might be dangerous ones that we need to take out. The other role is if we're trying to plan a high-risk operation, or we're working you up for transplant and we need to work out, is their liver up to the chop of the stress of an operation or transplant, then we also commonly will do biopsy to help us understand how healthy the liver tissue is, because cardiothoracic surgery or transplant is like a massive stress test on the liver. A lot of our blood clotting factors are made by the liver. And so what can happen if the liver's really sick when we do the operation is the person just bleeds a lot and their blood vessels dilate and all these toxins get into the bloodstream and that person can get very sick. So in my view, and I think most of the guidelines would agree, that they're the only indications for liver biopsy. Kate and Julian, would you add anything to that?
No, absolutely
No.
agree. They're used very, very little and needed, and
very painful and upsetting.
Yeah, and horrible. So,
and it's not going to change the way we monitor you or care for you. So.
No.
Yeah, one thing I might add about transition and some of these investigations or checks, I do speak to young people about the liver and the liver health and the reasons for monitoring, and that the tests are, likely non-invasive and fairly simple to do. I sometimes, get the impression the response is, oh yeah, whatever, that's fine. It does seem that some of these complications or bumps in the road, aren't seen in childhood, and so we don't dwell on it so much, and then they come, back to the adult clinic, and then I never heard that that was going to be an issue, which is understandable in a way, but I guess people do need to know that these things are being checked and will need to be checked on a sort of lifelong basis.
I think most guidelines now recommend screening from 10 years after the Fontan circulation, but
yeah, 5 or 10.
Yeah, it's not
5 or 10.
Not necessarily been embraced by every pediatric cardiologist, and we're the ones that get the annoyed patient saying, "Well, no one's ever said this to me before. Why are you doing all these things?"
I mean, I have 2 teenagers, and so it is like, okay, whatever. No, but it will generally start around 5, maybe a little bit. A few years after the last, the Fontan operation, but we'll need to continue thereafter.
Fab.
Excellent.
Jane, Pat, did you want to ask Kate that last little question from Larissa, or do you want to wind it up? What would you?
We've got like 1 minute. We can ask one question, don't we? And then we'll wind it up. Is it morning tea after this? I'm trying to remember what's happening after this. Okay.
Morning
we'll ask you one question. Yeah. Yeah. So Larissa asks, it's more about the arrhythmia section we talked about at the beginning. What heart rate is considered slow? I've noticed my 4-year-old's resting heart rate has dropped to 60. Post-Fontan, pre-Fontan, it was in the 80s.
So we allow you to have a very slow heartbeat if you have no symptoms and the rhythm is normal. So the ECG has the right number of little hills and big hills. We allow people to have very slow heart rates down to, well, if you don't have symptoms, we wouldn't check it. But there'll be plenty of people who have heart rates in the 40s, particularly those who are fit. And as they get older, one of the things that you might be noticing about your child is just that the heart rate gets slower as they get older anyway. So kids have a much faster heart rate than adults do. So, but 60s, I think, was in the chat. That's perfectly normal. That's completely fine. Sometimes Fontan surgery can there's some damage to the electrical wiring system within the heart, so sometimes you do see slightly slower heart rates afterwards, but that doesn't sound like anything to be concerned about.
Thanks, Kate. Well, we might have a little break now. We're perfectly on time for once, and we'll be back here in half an hour.